Good morning, everyone. Good morning, everybody. Welcome to the Trauma Grand Round this morning. Our speaker today is Kelly Brown, who's one of our advanced trainees in emergency medicine at Royal Perth ED. And the talk today is a little bit scary but compelling viewing on violence and aggression in the ED. It's something that we face and are exposed to in our workplace every day, unfortunately. I see there's some people that have joined us from WACS as well, and it's a problem all around WA. And I think in some of the sites, around the state, there's a lot less resources in terms of security and people that can help you when you do get a violent patient, so it can be even more frightening. Please welcome Kelly, and I'm sure it's going to be very interesting.
Thanks, Dave. Okay, morning everyone. As Dave said, my name's Kelly. I'm one of the ED Regs. I've worked in Royal Perth since about 2013 and on and off, and most of my time in the ED, some in ICU, and also worked in the trauma team as well. So I've certainly seen this topic from all sides. So just to let you know what we'll cover today. So violence and aggression towards health workers is an escalating problem. There's a zero tolerance policy, and the public health have a specific sort of position on this, which we'll cover. We'll also look at the statistics here at Royal Perth and the trauma and the association with violence and aggression and what factors contribute to that. Then we'll look at the legal responsibilities of doctors in terms of duty of care. We'll briefly discuss the WISE study, what we're doing in the ED at the moment, and then we'll have some time for discussion at the end. So, violence and aggression towards health workers. Just a bit of context for you all. I want to start by painting a picture of the level of violence and aggression that we are seeing in ED at the moment and in the public health system at large, just before moving on to a discussion surrounding the specific issues with regard to trauma patients as I go through the talk. So, violence and aggression towards health workers is, it's been in the media quite a lot lately. And at Royal Perth ED, as Dave alluded to, we see acts of violence towards staff and towards other people every single day. And sadly, it's become the rule rather than the exception. So in ED, there's definitely a strong correlation between drug and alcohol use and violence and aggression. Anecdotally, we see this, and we're also in the process of collecting concrete data at Royal Perth to try and actually get some numbers as to how much drugs people are using when they're aggressive in the ED. There's also a strong association between trauma and drug and alcohol use. So I guess it follows that there'd be some overlap between those two groups of patients. As well as alcohol and drugs though, there are other factors to consider in trauma patients that can make violence and aggression more likely potentially, as well as some serious risks that we need to evaluate when we are dealing with trauma patients. So just briefly, I want to touch on some studies and trends from around the world pertaining to violence and drug use. So according to the World Health Organization, 5.8 million people die from injuries per year the world over, and approximately 1/3 of these injuries are sustained from acts of violence. So also the World Health Organization Global Status Report on Alcohol and Health clearly shows the association between alcohol use and violence and accidental injuries. The Australian Institute of Health and Welfare have also recently released these two reports, one on alcohol, tobacco and drugs, which was released this year, and another, the National Strategy Household Report, which was done in 2016. Both of these show increasing drug use, particularly methamphetamine treatment and need to treat people has doubled over the last 5 years, and also it clearly shows an association between alcohol and accidental injury. And then, of course, the other interesting thing was in the drugs survey, it showed 1 in 10 Australians have been a victim of an illicit drug-related incident. So Violence is a major health issue and it is strongly associated with drug and alcohol use. In the area of emergency medicine and trauma, where we treat the victims of violence, as well as those who are drug affected, it is important that we are aware of this issue. The talk will mainly focus on violence and aggression we see within the emergency department and important considerations specific to trauma patients. So first, now I just want to show this video. So this is a video of that hit the media last year, which shows an attack on one of our registrars in ED. It highlights the increasing aggression from patients towards health workers. I've decided to show this video from Channel 7 because it also has an interview with the Chief Executive of WA Health Services, Liz McLeod, and expresses some of her views around the issue. Right. Have a look.
4:30 a.m. in Royal Perth Hospital's emergency room. A patient helps himself to a drink of water before exchanging pleasantries with the doctor. All appears normal as he walks away. Then, out of nowhere, he doubles back and lunges at the doctor, who has his back turned, working on a computer. With his arms around the doctor's throat, the man drags him to the ground. Nearby staff are quick to react. It takes 6 of them to break the chokehold and free the victim before security guards rush in.
I was absolutely appalled, bewildered and distressed that we can have incidents like that in our hospitals.
Last year, there were around 6,000 incidents of aggression at Royal Perth and Armidale hospitals. It's become so common, doctors and nurses now come to work expecting to be abused.
We're concerned that as employers that we can't actually provide a safe working environment for our staff.
That's despite increasing security in the ED, training staff on how to deal with violent patients and providing personal duress alarms.
We can do our bit, but we need everyone else to join us in saying this is not something we will tolerate.
The 21-year-old responsible for this attack pleaded guilty. He was sentenced to an 8-month suspended term of imprisonment and was released on bail. The court was told in the weeks leading up to the attack, the man had been in and out of hospital many times for serious mental health problems. And that morning, he felt he wasn't getting the treatment he needed. And while he didn't wish any harm on the doctor, he told his lawyer, "I just wanted attention. I simply needed to do something drastic." The doctor wasn't badly hurt and is back at work.
We understand people are feeling vulnerable, distressed when they come to our hospitals, but the best way for our staff to be able to care for people is to feel safe in doing so.
Rob Scott, 7 News.
Just go back into it. So, pretty compelling viewing. And certainly highlights the problem that we face with increasing violence in the emergency department at the moment. But that's just one incident of violence towards staff here at Royal Perth Hospital. There's been countless more. Let's now look at more of the media coverage surrounding violence and aggression in the emergency department. So this is just some of the articles that I've found over the last 2-3 years. There's plenty more. But one of these articles cites that 11,000 violent and aggressive incidents were reported during 2016 and 17, leading to the Government of Western Australia promising the rollout of stab vests and personal duress alarms over the next 3 to 4 years. Another cites that there's been a 30% increase in code blacks from the year 2015 to 2017. Another article, the AMA spokesperson, David Mountain, for the emergency medicine AMA spokesperson, attributes the increase in drug and alcohol use as well as the decreasing respect for hospital staff that is the leading cause for staff suffering daily abuse. So certainly attributes it to the drug and alcohol problem we have. So violence and aggression in hospitals poses a threat not only to us as staff and doctors treating patients, but also to patients themselves. And when those patients can have, severe injuries, it makes the issues that much more important. So what is the position of the Health Department on this? This statement is from the Department of Health's Prevention of Workplace Aggression and Violence policy. It states that a health worker employed by the Department of Health is a public officer for the purposes of the Criminal Code. Accordingly, any person who assaults a public officer who is performing a function of his office or employment is guilty of a crime and liable for imprisonment for 10 years. Just interesting to note that the patient that assaulted our registrar was awarded an 8-month suspended sentence and released on bail. The guidelines also state that employees have the right to work in an environment free from aggression and violent behaviour. Further to this, the government promotes a zero tolerance policy on violence and aggression in the hospital. The idea of this is that if patients are violent or aggressive, they will be refused care. But we all know that it's not as simple as that when we start to consider potential for impairment of decision-making capacity. So, how bad is it at Royal Perth? I have to say that when I started looking into the research for this talk, and in my anecdotal experience working in the ED over the last 5 years, or 6 years including this year, I knew that the problem was getting worse, but I had no idea it was this bad. So these numbers were so astounding to me that I did go to the security office and ask them, has there been a change in the way they're reporting or anything? And they said, yes, there has been, but that change occurred at the end of 2014. So since 2015, well, the end of 2014, they've been using the same program and and by and large the same officers reporting it. So even if we ignore 2013 and 14, from 2015 to 3 years ago, we had 2,594 cases of aggression, and last year there was 4,002. So it's a 54% increase in episodes of aggression in just over 3 years. And to me, I think that's quite staggering. So this breaks it down a bit further. The statistic, so again, these statistics are from the security unit, and whether the incidents occur in ED, the rest of the hospital, or in mental health. This slide just takes us through the different wards and where the code blacks or incidents of aggression are reported. So rather than code blacks, I've actually used incidents of aggression because the security officers, whether it's a code black or not, will actually report it as aggression if the patient is aggressive verbally or physically. So it's a bit better measure than looking at code blacks. So as you can see, the State Major Trauma Unit has the highest number of code blacks or incidents of aggression. And then AMU ACU, they have a lot of patients and a high turnover. And then 5H as well has a lot, and which is the neurosurgical ward, which is largely occupied by brain trauma or traumatic brain injury patients. And I've included any ward that had more than 20 violence and aggression incidences in the year of 2017, and I've omitted the rest. I also omitted, communal areas like the cafeteria and the car park, which also have a lot of episodes of aggression as well. So that just gives you an idea of where people are violent and aggressive. So this data is actually from the trauma registry as well, and it shows the link, as we see daily in ED, there's an association with drugs and alcohol and aggression, but also these statistics show us that there is an association between drugs and alcohol and trauma as well. So, this data comes from the trauma registry, which is collected from the notes. They actually go through and see whether it was reported that the patient was using alcohol or drug, which largely comes down to the patient reporting that and saying, yes, I've been on alcohol or drug. So it's likely that it's an underrepresentation of the level of alcohol and drug use in trauma patients. But surprisingly in some ways, I guess these figures remain pretty constant over the last 5 years, still roughly around 20%. But even if it is an underreported statistic, I still think 20% is a pretty decent share of the numbers. And how does that actually, in actual terms, so if we look at 2017, 19.37% of trauma presentations were reported as being related to drug or alcohol ingestion, which makes it 1,100 trauma cases in the year of 2017 were related to drug and alcohol. So, and just breaking it down into some individual areas, if we look at motor vehicle crash, the drivers are 20% of the time are drug or alcohol affected, and in motorbikes it's 18% of the time. So, what are the other sort of contributing factors to think of in terms of violence and aggression and trauma? So, violence and aggression itself contributes to trauma. People get into fights, they get punched or they get stabbed, and they have a traumatic injury as a result of violence and aggression. The other thing is trauma itself can contribute to violence and aggression. So patients can be agitated as a result of their injuries or the attack. It's a highly emotionally charged situation to be in. And then, as I mentioned, drug and alcohol use, as the statistics show, even though they're probably underreported, there's an association between drug and alcohol use and trauma, as well as drug and alcohol use and violence and aggression. Then there's social factors as well. Employment status, low socioeconomic status all contribute to violence and aggression, and as well drug and alcohol use, we see an association there as well. So all of these factors need to be considered in any strategy to try to reduce violence and aggression, as well as preventing potential harm to patients and harm to staff as well. So, violence and aggression in trauma patients. This advertisement is from an ad campaign in the New South Wales Government, which highlights the association between violence and alcohol abuse. So in our emergency department, we often see violence in trauma patients who are drug or alcohol affected. We have data from our security unit showing us that there's a high rate of violence and aggression reported on the trauma ward as compared to other places. And due to this association, as well as other factors which make trauma patients quite unique, it is worth considering, it's worth investigating the potential causes of aggression, violence and aggression in trauma patients, with a view to reducing any factors that we can change, and also being aware of the potential risks associated with traumatic injury. So how are trauma patients unique? This CT scan was performed following an attempted suicide. The patient had shot himself in the head with a nail gun. He presented with a wound on his forehead, hemiparesis and neglect. The first picture shows the entry wound, so that was the wound on his forehead, and the second picture shows the nail in situ, which is a 65mm nail. His GCS was 15. So I chose this case to show that sometimes traumatic injuries can be far worse than they appear. So trauma patients can have very severe, almost occult injuries. Traumatic brain injuries can be insidious. Someone can be highly agitated, lack capacity, and they may insist on leaving the department. There are other complicating factors that we often see in ED, come across in ED, such as the patient may be under arrest, and of course they may be drug affected. So there's a recent case in Royal Perth ED, and unfortunately I'm unable to show the CCTV due to people not being identified in it, but I'll tell you about the case. So this chap was post-assault, trauma patient, full spinal precautions, and he was under arrest. So the two police officers are standing next to him, and he's lying in a bed in CC4 in ED. He then starts to get angry. He starts kicking and screaming. He overpowers the two with his spinal collar on. Overpowers the two police officers, jumps out of the bed, runs down the length of ED, runs back, runs through the resus phase, and ends up legging it towards the door. Two of our security officers stopped him, and he was put back into his bed and treated. So I guess what that highlights is there's no way that person has decision-making capacity. He is more concerned about escaping arrest than he is about making sure his neck isn't broken. So, I mean, here at Royal Perth ED, we are no strangers to restraining and stopping patients who are drug affected and lack capacity. That's something we do all the time. But when the person is a trauma patient, they may have life-altering, severe injuries that are yet to be diagnosed, and that makes our duty of care with regard to their treatment all the more stronger. To put it another way, the nature of trauma patient injuries means that they are at higher risk of morbidity and mortality than some of our other patients that present with violence and aggression. Trauma patients can also have very high-risk injuries. So this patient, the CT and MRI scan was performed here. This patient was transferred from Bali, and he was transferred not in spinal precautions. He was ambulant, and on assessment, he was transferred to the ICU here at Royal Perth, and on assessment he reported transient paresthesia across his abdomen, leading to these scans. So I very much doubt that this injury would have been missed if he presented to Royal Perth Hospital at the first instant, but regardless of which, he's very, very lucky. So violence and aggression in trauma is a bad combination. As this illustrates, the injuries that trauma patients can have can be incredibly high risk, and due to factors such as traumatic brain injury or alcohol and drug use or severe pain, psychological stress, the capacity of the patient can be compromised. And it's incredibly important consideration for us in ED when we are dealing with trauma patients. The next thing that makes trauma patients unique is that they can have really severe injuries and be in incredible pain. So these two x-rays were taken of the same patient at the same time in different trauma bays. So his arm was ripped off his body while he was working at a factory with a conveyor belt. So trauma patients, as you can see, can have horrific injuries. This patient was very agitated when he came into Royal Perth, and he required a lot of analgesia, including ketamine, to settle him down. So, because he was suffering such immense pain. But also, because of the nature of their injury, such as this one, patients can be overcome with the reality of how severe their injury is. This guy's right arm had been ripped off his body. It's very hard to process that sort of thing, and it can really add to someone's level of agitation. So both of these factors need to be addressed promptly to reduce agitation and potential aggression in trauma patients. And the next thing that makes trauma patients unique is that often two people or two parties will be involved in the same accident and treated at the same place. So this photograph is from a motorbike crash versus car. Two victims of the crash were brought to Royal Perth Hospital on a priority 1 and arrived at very similar times. One patient died in ED and the other survived. And both families were present in our emergency department waiting room, and there were code black after code black after code black because of family aggression. So families are understandably distraught and upset, and they're going to be in close proximity. And this is something we see up on ICU as well, is when patients are in there and there's two patients who are, that we can separate them inside the ward. That's one way we can deal with it, but it's very hard to deal with the issue of families being in the waiting room together, especially in situations like this where someone has died and another person has survived. So it's another consideration we have to have when we deal with trauma patients. So now that we've considered the risks associated with trauma patients and their severe injuries, I want to talk about the legal responsibilities we have as doctors in this situation. So firstly, let's look at the WA Health Consent to Treatment Policy from 2016. It states that in an emergency where a person is incapable of giving consent, treatment may be provided without consent, i.e. where treatment is necessary to save a person's life or prevent serious injury to the person's health. The treatment in these cases is that which is reasonably required to meet the emergency in the patient's best interests and the least restrictive of the patient's future choices. In these situations, the completion of a consent form is not required, but the circumstances that constitute the medical emergency and the patient's inability to consent must be clearly documented in the medical record. So basically the policy is that emergency care should be given to anyone without capacity or ability to consent wherever that care is appropriate. Then moving on to our legal responsibilities. This article was published in the Medical Journal of Australia in 2014 and addressing the concerns in the context of the current legislation. It's worth reading if you have the time, but I'll just go over a few points that are very relevant to us in this discussion. So firstly, Australian states and territories have guardianship legislation that provides some mechanism for substituted consent once it is clear that the person lacks decision-making capacity. Secondly, it states that there is a basis at common law for lawfully restraining patients in circumstances where there is suspected incapacity and where the restraint is necessary for the protection of the patient or others. Restraint could be applied only so long as the necessity prevailed or until other means of consent would be resorted to. And thirdly, doctors owe a duty of care to their patients to provide advice, care and treatment. The care provided should be of a standard that would be widely accepted by peer professional opinion as competent professional practice. Doctors are also under a duty to provide patients with information that any patient would feel was relevant to the decision at hand, and any other information that the doctor should have known would be important to the patient. That's a bit vague, so we're supposed to know what would be important to patients and provide them that information, but unfortunately this has been tested in court. So when a patient refuses to wait for full assessment, there is a duty to at least provide appropriate advice. The New South Wales case, Wang versus Central Sydney Area Health Service, the court found the health service was negligent because they failed to provide a young man with advice on a head injury who decided to leave the emergency department waiting room without being seen by a doctor. So it's an important issue. And finally, the courts place a high value on personal autonomy. However, autonomy is lost where decision-making capacity is lacking, and it is not recognised. Individuals may be deprived of necessary treatment in cases where there is good reason to suspect that decision-making capacity is impaired. The treatment refusal may involve considerable risk. We have to clarify the situation as soon as possible, and breaching that duty can give rise to legal consequences, as was seen in New South Wales. So, duty of care. This photo is of a patient who was violent, aggressive to start, and drug affected in drug-induced psychosis. Surprise, surprise, he was on methamphetamine. He was physically restrained and then chemically restrained in ED under duty of care. A large proportion of the patients who are violent or aggressive in ED are drug affected and lack capacity. Violent and aggressive patients also pose a significant risk to themselves and others. So they fall directly into that category of patient who needs to be restrained until they no longer pose a risk or until their capacity for decision making returns. So in the concept of trauma, in the emergency setting, we have the same legal responsibility. Patients involved in trauma who may lack capacity due to intoxication or head injury, distress, pain, reduced conscious state, are violent and aggressive and are wanting to leave our emergency department, they may need to be restrained until their capacity to make decision returns. So when restraining trauma patients, however, as I've highlighted, we have to be cognizant of the potential severity of their injuries and the risk of further injury as well. So it's just something that we really need to consider when we are acting on these laws in regard to trauma patients. So it's very clear that the zero tolerance policy does not apply in this situation. If you're interested in the laws that cover us here in WA with regard to duty of care, providing mechanisms for substituted consent is under the Guardianship and Administration Act of 1990, and defining doctor's standard of care is the Civil Liability Act 2002. So what have we done at Royal Perth to address this issue? So we now have 5 security officers, which we previously, since about 18 months now. Previously we only had 4. So due to the increasing need to be present in ED, security officers raised concerns surrounding their safety and patient safety, as well as our staff safety. So they were asked to have a meeting with the CEO of the hospital and requested an extra man, and they were granted that extra man. So there's now 5 of them. So just to be aware of the system with the security officers, 1 is in the control room at all times. So they're fielding calls, opening doors and watching the cameras. So if we have 5, it means we only have 4 on the floor. So So now there's 5 24/7. And interestingly enough, the very weekend after they were granted the 5 security officers, there was an assault on a nurse in ED, and they had an extra man in security who attended the assault. And if he hadn't been there, it could have been a lot worse than it was. So we have done that. There's also training of staff. We have management of aggression training here at Royal Perth, which includes hands-on training with regard to keeping yourself safe, keeping patients safe, and safe restraint practices on patients as well. And then, of course, the government has now promised us $2.2 million dedicated over the next 3 years, which will largely be spent on stab vests and personal duress alarms, but I'm not sure exactly how well that's going to protect us. We'll see, I guess. So what more can be done? So an approach to prevention of violence and aggression is covered in the World Health Organization report into interpersonal violence and illicit drug use, and it states that while rigorous studies showing the effectiveness of intervention and prevention initiatives, there's no rigorous studies that have been done, there's no huge body of evidence, but all of the available evidence suggests that prevention programs at the community level can have some positive outcomes. So most of these are targeted at young people as well, because young people are the most vulnerable in terms of setting up, lifelong habits of drug use and violent and aggressive behaviour. So there's school, community-based prevention, family-based behavioural therapy, mentoring programs, reducing supply, and of course the government is very much interested in reducing supply and access to drugs as well. But that sort of falls outside the scope of us in the health system. So the same document from the World Health Organization does talk about the role of public health agencies in preventing violence and drug abuse. And so collating and disseminating intelligence, advocating for a policy to reduce drug use and violence, and identifying, informing and developing, implementing, evaluating interventions. So I guess a huge part of it for us is going to be research and actually getting a handle on what the numbers are and where the issues are. And unfortunately at this point we don't have those sorts of numbers because it's all reported sort of anecdotally. We don't have hard data on how much drugs people are using and where the biggest problems are, but we are getting a better handle of it. And as we do get a better handle of it, we then need to direct our interventions towards addressing those problems. But how we are collecting data here at Royal Perth, leading on from that, we've got a WISE study in ED. Dr. David McCutcheon will come up in a second and have a chat about that. But basically it's about actually getting some numbers in terms of what drugs people are using when they come in to ED and they're aggressive. Then perhaps there is, going forward, there's room for a similar trial in regard to trauma patients to further actually evaluate how bad the problem is with the use of alcohol and drugs. So just to summarise what I've talked about so far, violence and aggression is an ongoing hospital-wide problem. There are specific considerations that we need to be aware of when we deal with trauma patients. We have a duty of care towards these patients as we do with every other patient in the hospital. We need to be aware of the risk of violence and aggression in trauma patients, and there's room for a discussion surrounding the issue of minimising risk to patients and staff going forward. So I just want to now hand over to Dave McCutcheon to have a brief chat about the WISE study.
Thanks very much, Kelly. Some of those slides are really scary, particularly just the increase in violence that we've seen year on year. So it's definitely felt that, but to see those in numbers is really amazing. So yeah, it's certainly very scary. The WISE study, I'll just briefly touch on, is a study we've been running for 2 years now, looking at illicit drugs in the ED. It was set up to look for novel psychoactive substances, which are some of these new drugs that are coming onto the scene, and there's about 400 or 500 of them that have been identified over the last few years. The study, basically, anyone that the treating doctor thinks is intoxicated with drugs at the time, a de-identified sample is taken and frozen and later analysed to see what drugs are in there. We get levels of the drugs as well as the names of the different drugs in there. So some of those patients do include trauma patients. I don't actually have any results yet. We're just starting to analyse the first 2 years of data, but a lot of the trauma-related ones are due to methamphetamine, which is pretty common. The latest Australian Institute of Health and Welfare data was that 2.7% of West Australians have used methamphetamine in the last year, which is absolutely staggering. That includes all adults, I believe, which is a decrease, believe it or not, on the 3 years earlier. But yeah, still it's a huge social problem, and I think all of the stuff that you've talked about with violence in the ED is a society-wide problem that just rears its head in the ED. Yeah. So the WISE study is going to give important information on methamphetamine levels in the ED. It's not going to tell us what proportion of trauma patients have meth, because otherwise we'd have to test all of the trauma patients. But certainly we are collecting data on some of the patients with injuries, and that's going to be pretty interesting.
Thanks, Dave. Okay, I just want to briefly say thank you to the Trauma Registry for giving me the data they gave me. Jenny Chambers was great in getting that for me. The Royal Perth Security Unit, Jeremy Coulson gave me the statistics for that I discussed, and then obviously Ag and Dave, who helped me with my talk. The head of security, Jeremy, was hoping to be here this morning, but he's texted me and said he's unable to make it. So unfortunately he's given his apologies. My references, if you're interested, and I guess we can have some time for discussion now about this issue. Tahi.
Thanks very much, Kelly. In terms of the types of assaults and violence that staff faced, was there any breakdown of what kind of injuries and what types of assaults? In other words, for the stab vests that have been put out there as a protective feature that we may have unilaterally enforced upon us, is that something that will be protected against? Are there stab injuries that we...
Unfortunately, no. The way that the security officers report their incidents, they can break it up into different tabs, and basically aggression is the most common one, and it encompasses whether they're violently aggressive or verbally aggressive. They put it under aggression. They do write a log, though, security officers, about what happened and whether there was someone who was assaulted and stuff, so that information is in the security's log. And also they do also make comment as to whether they had to go hands-on or not, but they don't make comment as to how severe the injury was or anything like that. I mean, they're not qualified to make that assessment. And the data that I've got is from the security team, so it's a bit... no is the answer. And will stab vests help us? I don't know. I don't think many of the injuries reported have been stabbings.
It's a really good point, though. Maybe forward-looking, the hospital need to actually document what injuries are sustained to actually look at more specific.
I imagine that in the choir incident, they're putting the choir forms in, they would have that information in the choir form. So I guess that is certainly something we can look at collating.
I think we would all reject the idea of wearing something unnecessary at work. So if it's going to be enforced upon us or shoved down our throats, it'd be great to say this is the number of injuries that we sustained. They're all blunt force, stranglings, and chokings.
Yeah, and there's probably better ways to spend the money, right? If it's not something that is. But having said that, if you prevent one stabbing towards, and maybe security officers could wear stab vests because they are doing searching of patients. They take knives off patients all the time when they search them. So maybe it is appropriate for them to wear them, but certainly probably not for doctors.
Maybe they could give us all tasers. Are there any questions from any of the country sites?
No, thank you. That was really good.
No worries. Any more questions here?
Dr. Rao.
You do need to repeat the question into the mic, otherwise they won't hear it.
Oh, so, yeah, certainly.
So how do you get consent for keeping the blood and testing the
Oh, you're talking about the WISE study. So it's been approved for a waiver of... So the question was about taking the blood samples for the WISE study. So that's had ethical approval to collect the samples under a waiver of consent. And the discussion with the ethics was around about they considered the risk to the patient would be of perhaps our research records being subpoenaed and the drugs, being us having to disclose the drugs that were detected in the patient. So we've had to do a very extensive de-identification process where the samples are permanently de-identified, so there's no way we can actually trace back which patient the sample has come from. We have a 2-week window after hospital discharge which allows us to collect some clinical data to relate to each sample, and then all links between the patient ID and the sample and the data are destroyed. It's actually on a piece of paper that we shred. So that was required by ethics as an additional precaution. The problem is you can't get informed consent from someone that's on drugs because they could always contest that in court, and often they're completely off their head. So it's not something you can do up front, and delayed consent has a lot of problems because, say, if you email someone or write to them or phone them up, depending on who they're around, you might be disclosing that they've taken illicit drugs to people that they don't want to. Obviously, you can't phone their mum and ask them for participation. So, it's a difficult area to do research in, and so that's the way we've come up with doing this study.
Kelly,
Yes.
how do you think we'll be approaching this in the future? Is it still the same, physical restraint?
The question is, how will we approach this in the future, and will we continue to rely heavily on physical restraint? I think from what we see in the emergency department, certainly we do physically restrain people until we chemically sedate them, and once they're chemically sedated, it is not practice for them to be physically restrained at the same time, so it's either one or the other. I guess the issue is that we saw that video of Paul getting attacked. We've seen nurses in our ED get seriously assaulted. We've seen one of our psychiatric nurses was almost knocked out within the last 6 months. So the threat to staff is very real, and I think that we have to be very proactive, and if that means physically restraining patients and chemically restraining them for our safety, then I think I'm not sure what other option we have. In this situation and the climate as it is at the moment, I'm not sure what other option there is.
Okay, thanks very much, Kelly.